is Cholesterol Month. I'm Dr. Ralph Abraham from London Medical, and I'm going to talk today about patients who are unable to take a statin. They may already know that they are at high risk of a heart attack, perhaps because a loved one has passed away prematurely, or because they know their family history is bad, or because they smoke cigarettes, or because their GP has discovered and told them that their blood cholesterol is high. The first response is often to recommend medication with a statin, and if there are any side effects, the statin is often stopped. If not by the GP, then by the patient themselves. I have now seen over many years, many patients who have not been offered any alternative protection for their risk of future heart attack after their first initial prescription with one of the statins, which was then stopped because of side effects. What should one do if this is the case? There are many alternatives, and it is very important that this is taken seriously. First of all, not all side effects are due to statin use. There are well-known side effects attributable to various statins, but there are also many other side effects that are clearly unrelated to therapy with these agents. I remember one week in clinic in which 4 patients consulted me for statin-related side effects. And all 4 of them had other conditions which had been missed and which had nothing to do with their statin therapy. The conditions varied from vitamin D deficiency, which is common, to spinal canal stenosis, hydrocephalus, and multiple sclerosis, all of which are quite uncommon. So alternative diagnoses always have to be looked for. So it's important that your doctor takes a good history and thinks hard about the possibility of other diseases before making a decision that you really have to stop or change your statin. After this, one should think about using a different statin. All statins are not the same. There are water-soluble as well as fat-soluble statins, and statins that are metabolized differently once in the body. Or the statin dose could be reduced to see if the side effects disappeared. But if you are one of the rare patients who are unable to take any of the 5 available statins, and such patients do exist, and you always get muscle stiffness, cramps, or weakness, then it may really be that you are unable to take one of these wonderful drugs, which are known to be so protective for coronary heart disease in the future. You may have genetically inherited one of the many transporter defects, which lead you to have much higher levels of statin in your blood than other people. The talk today highlights the fact that there are many other drugs that should be used to lower LDL cholesterol. The mantra now is that the lower your LDL cholesterol, particularly if you are known to have a high risk for cardiovascular disease, that means heart disease or arterial disease, the better. So what are the other options in terms of non-statin therapy? The first is ezetimibe or ezetrol, and this can lower the LDL cholesterol by as much as 20%, but it doesn't have the anti-inflammatory properties of the statins. It just lowers the LDL cholesterol. But if you cannot take a statin, you can at least take ezetimibe. And as this medicine sits in the lumen of your bowel, stopping cholesterol being absorbed into your body, it is relatively free of side effects. The second option, particularly if you have diabetes, or you have raised triglyceride or fat in your blood, or a low HDL, or good protective cholesterol, is Phenofibrate. Phenofibrate is a relatively old drug that is also generic and so inexpensive. And we lipidologists would use it in combination with a statin in patients who have what is called familial combined hyperlipidemia or dyslipidemia, when their abnormalities are characterized not just by raised bad cholesterol, the LDL cholesterol, but also they have a low level of good protective HDL cholesterol and raised triglyceride. This group of patients often have a very high risk for early coronary artery disease. Phenofibrate is a good drug, though it is not as strong as a statin. It will still give you some useful LDL lowering. Once those three drugs, which are generic and relatively cheap, are used, we begin to enter the new world of new and expensive drugs, which have been developed to deal what doctors call residual risk. This is the risk remaining even when maximum doses of conventional medication are used, and it's really directed at the 25 to 30% of patients who still are at risk of a heart attack despite conventional treatment with maximum doses of statin and ezetimibe. This residual risk is a substantial cohort of patients, and many of them have diabetes. Diabetes patients, as we all know, have to worry mainly about heart attacks and strokes. But if they survive that, they have to worry about arterial problems in their legs, which make them vulnerable to amputations. The level of amputation in this country is still of concern to every person with diabetes and every diabetologist. So keeping arteries flowing for as long as possible remains one of the most important jobs of a diabetes doctor. I'm going to talk first about the PCSK9 inhibitors. The PCSK9 inhibitors are a fascinating story of a very fast development of a drug to lower LDL cholesterol, which derived from studying the genes of people who had suffered heart attacks early in their life. The abnormal gene found was the PCSK9 gene. It was really only 6 years from the discovery of the gene to making an inhibitor of the gene that was commercially available to patients to reduce the risk of heart attack. There are now 2 drugs available commercially, Repatha and Praluent, and both of them lower LDL cholesterol substantially, open up arteries, and reduce the risk of heart attack and stroke in patients at high risk. They are expensive. Praluent, or alirocumab, and Repatha, or evolocumab, are taken by injection every 14 or 28 days. They are very powerful in lowering LDL cholesterol, particularly if accompanied by a feeder dose of statin. Because the feeder dose of statin is kept very low, side effects can be avoided in patients who are sensitive to them. They can be used with all other lipid-lowering drugs in an additive fashion, so that extremely low levels of LDL cholesterol can be achieved. And this becomes important in patients at high risk who have had many previous years of no or inadequate treatment of their LDL cholesterol, and who have already accumulated substantial atheroma. By this time, arteries all over their body are narrowed or severely blocked. We have little time in such patients, and the need for regression of atheroma becomes paramount, and this can now be achieved with very low levels of LDL cholesterol, so opening up their arteries wherever possible. We now know that the lower your LDL cholesterol, particularly levels below 1 millimole per liter, can show detectable regression of atherosclerosis. So we can improve patients who are already in dire straits, and those patients really need these drugs, even though they are expensive. So I do recommend these drugs and prescribe them to patients of mine who I feel need regression of atheroma, or where the risk of a cardiovascular event is already extremely high, or when they are totally intolerant of all statins. Or sometimes because their current combination of drugs doesn't give them sufficient LDL cholesterol lowering. Apart from their expense, the good news is that these drugs do not have significant side effects, and they are well tolerated. Inclisiran is another drug that works on the PCSK9 system and is similar, but it works in a slightly different way and is not yet available this year. It's likely to be available next year, and it will be given to patients by injection every 6 months and will achieve much the same effect as the current PCSK9 inhibitors. It is believed to have as good a safety profile, and in the absence of significant side effects, if it becomes cheaper in price, it may become a real option then for patients who are totally intolerant of statins, who have a high risk for coronary artery disease or stroke, and who are not effectively protected from their risk by their current medication. Lastly, and fresh out of the blocks, is the new drug bempedoic acid, or Nilemdo. This has now been passed for use in Europe, but is not yet available in the UK. Again, it might be available early next year, and it's believed to be cheaper than the PCSK9 inhibitors. Bempedoic acid is important because it has 2 star points that single it out for special use in certain circumstances. First of all, it's very similar in what it does to the liver cell in preventing it manufacture LDL cholesterol as statins, except it works at a different step, and this step doesn't exist in muscles. So bempedoic acid is a statin that doesn't have muscle side effects. It has an equivalent substantial reduction in LDL cholesterol, so it's going to appeal to any patient who has had substantial side effects with any statin. It's also going to be useful as an add-on to statins because you can get an even greater LDL cholesterol reduction taken with statins. And this may turn out to be as substantial as that currently achieved by the PCSK9 inhibitors on their own. When a person's LDL target is really known because somebody knows their cardiovascular risk quantification has been assessed and is found to be high, one can set a patient a low LDL cholesterol. Few patients have a coronary artery calcification score or quantitative carotid ultrasound studies or advanced lipoprotein subfractionation as we do at London Medical. Treatment is and should be proportional to risk, and few patients have this access to such heart disease risk assessment. Bempedoic acid does have another problem, as it tends to raise uric acid, and so it's not going to be suitable for any patient that already has gout. Other than that, of course, we always have to remember that new drugs are an unknown quantity. Side effects sometimes take many years before they become apparent. I want to leave you with the thought that if you can't take a statin and you know that you have some risk factor that makes it likely that you are at high risk for an early heart attack or stroke, it is not sufficient to do nothing. You really have to treat that LDL cholesterol, and there are safe, effective ways of doing this. And if you need a specialist in heart disease protection to advise you, they do exist. They know about all these drugs and their side effects. They will help you find a combination of drugs that will lower your LDL cholesterol substantially and appropriately for your risk. And you will be far better off over the next 10 to 30 years than if you did not do this. There are some who believe that the entire population should have an LDL cholesterol similar to that we were born with and that exists in the wild, which is closer to 1 millimole per litre, which puts most of us in the Western world at having too high an LDL cholesterol. But attempting to approach that and achieve an LDL cholesterol nearer 1.5 millimoles per litre is sensible for anyone who already knows that their family or themselves are known to run increased risks of an early heart attack or stroke, or who have erectile dysfunction, or who already know they have blocked or narrowed arteries, and of course, all people who know they have diabetes. So take these points seriously. And if you have had trouble with statins in the past and have given up, I hope this talk encourages you to go and see your doctor and investigate alternative solutions. Thank you for listening to me. This is Dr. Ralph Abraham from London Medical.